Good evening, everyone. Uh, so we are on to our last session today on the Pain Educator, the Pain Collective Educator program, and it's one of the most interesting topic, which is very really close to all of us. I think as physios, we all of us want to know how would we go about chalking out an exercise program for our patients in pain, because these are the people who are actually very difficult to treat, and their pain, fluctuating pain levels, always adds up to our confusion. So let's begin with today's session. So exercise prescription for musculoskeletal pain. Am I audible to everyone?
Yes, ma'am.
Yeah. Okay. So first and foremost, even before we start, कैसे एक्सरसाइज प्लान करना है, क्या एक्सरसाइज देना है, let us discuss what exactly are the issues. This is something that I realized for practicing now almost for a decade, that there are certain issues which came to me as I was a learner, then I started practicing with pain patients. Okay, so let's see what are the exact problems that we have uh, when we see a person with musculoskeletal pain. Basically, there is an overemphasis on pain. Now, what do we mean by that? A person has come to you with pain. We start realizing that we are getting scared a lot with the pain. Okay. And we already know that these are the people who are having catastrophizing behaviors, who are hyper vigilant about their pain, and they are over cautious. So we as therapists, if we continue to focus our attention on the pain per se, and do not try to divert or educate them, we will not get anywhere near about in managing their pain and getting them out of it and helping them to be as functional as possible. So I used to get many a time students would come and tell me कि मैम आज patient 8 on 10 pain बोल रहा है, so let us just put him on modalities. 10 IFT करते हैं आज के दिन के लिए, and then once the pain subsides we will start with the exercises for the patient. No. Why? Even if the person is saying 8 on 10 pain, is there something that you can do? Calm the person down, make him understand what are the probable causes for his pain, why his pain has flared up, and then start with gentle movements or exercises. I think we will be doing a great deal to help such people. Okay. The second point which I have highlighted, I think which most of us, even we continue doing this up till unless 2 years now, which is medicalization of exercises. What do you mean by medicalization of exercises? We focus our attention too much on a specific condition. Okay, अगर डिस्क है तो मुझे एक्सटेंशन एक्सरसाइजेस से ही शुरू करना है, और आई विल नॉट गिव फ्लेक्शन एक्सरसाइजेस टू माय पेशेंट्स. लिस्थेसिस है, what do you mean by bias? If I have anterolisthesis, I am going to avoid extension exercises for my patients, or I will just give flexion exercises, or vice versa. And we focus a lot on technicality. Like many a times we end up telling our patients that, let's take an example of a simple shoulder bridge. We put a pillow between the knees. We tell the person, squeeze the pillow, tuck the tummy in. Now slowly lift your hips up, starting from your coccyx and slowly going up. All of these instructions are very good. But a person in pain is already irritated and frustrated. And so much of technicality will make him all the more frustrated. What we need to do is keep things simple. Biomechanics has its role for certain conditions, but if I lay a lot of emphasis ki for this particular exercise I need the pelvis to be posteriorly tilted only, and majority of patients, if you realize, do not have posterior pelvic tilt, they have less posterior pelvic tilt, and if I am then digging into getting that posterior pelvic tilt, I am increasing the fears around movement. So kinesiophobia gets exaggerated and the person will never be ready to exercise. Now, this medicalization of exercises is what I learned as a terminology from Ben Cormack's workshops. I would highly recommend his workshops are pretty small and good and decent and not very expensive. Online hote hain very regularly. So follow him for the updates, but his workshops really guide you and give you a new perspective of managing patients with pain. The last and most important problem that is we fail to understand what exactly is the problem. Has the person come to you with pain as a primary problem? If it is, then what are the probable influencers? What we discussed in our last webinar, we should be able to understand what are the probable influencers for the pain, what are the factors which are contributing or triggering to the existent pain. What is the exact pathology with which the person has come to me? If the person has come to me with tendinopathy, tendon as an issue, tendonitis bolo, so we should be able to understand what is the specific healing time of that structure. 6 weeks if it is tendon and the person has come to me say in third week with pain, I would still respect that probably the structure is still not being able to accept loads or is still very weak. Okay, disc hai to I know the exact timeline. So understand that you will realize what exactly is the problem only when you know that structure and its healing time in that specific condition. Okay, what impact does this pain has on the individual? So when we discuss about the principles of exercise prescription, we will talk about this in detail, but in understanding the negative pain influences, we discussed that pain is having an impact on the social, personal and the psychological aspect of the individual. So how is this pain affecting that person? Is he feeling a lot isolated? Is he feeling depressed? All of these factors are going to contribute to your rehab program. The person will cooperate with you or not cooperate depends on these factors. Okay, coming to the treatment principles. Now this is very interesting. We always, whenever we are talking out a exercise program, what we do, we would talk about we used to write, even in our management of let's say frozen shoulder, we'll write short term goals, long term goals. Short term goals, pain relief, then we have for patient education, then we would put pain relief, then we would get improve range, improve strength would be our short term goals. And long term goals में हम लोग लिखते थे aerobic conditioning and return to functional life. But what your goals are they making any sense to the person in pain? Okay, the first and foremost principle that you should follow is it should be making some sense for that individual, what they want, what are their expectations for coming to you, and also what is more important is what they need. Majority of these patients are patients with persistent pain and they are either not going to work, there's lots of absenteeism from the work, loss of productivity, so they are financially burdened. Okay, majority of them, if they are not from so affording families, going to the work is what probably they would need. So if you are not digging deeper into this, then whatever rehab you are chalking out for them will not make sense. Then what are the cherished values? What is it that they want to do eventually when they come out of the pain? Return to activities. So today I had an opportunity to see a singer who's got a query piriformis, query sciatica. We don't nowadays label these chronic pain uh, people, but her intention is she wants to go back to the gym. So my rehab should include exercises which will help her cope up with the gymming activities. Okay, so understand what are their goals, what are their expectations, what is it that they value in their life once they're out of pain. And the third principle, whatever sense making return to activities ho gaya, you identified. But what you have to do is reduce their fear of movement. We discussed in the first webinar about fear avoidance model. Okay, what is fear avoidance? They slowly become a can't do kind of a person. पेन है तो आई कैनॉट सिट ऑन द फ्लोर, पेन है तो आई कैनॉट बेंड फॉरवर्ड, पेन है इसलिए आई हैव स्टॉप्ड गोइंग फॉर माई वॉक्स. Okay, what is this slowly leading to? They are not moving enough, and if you are not moving enough, your health, your fitness levels start coming down, and your life, you end up into then isolation or depression and all of the psychological factors that we discussed. So remember that whenever you're talking out an exercise program, it has to make sense to the individual. So it has to be customized. It cannot be a tailor-made program. जैसे हमें ब्रॉड्समैन में protocols मिलते थे. We still many a times ask rotator cuff injury है तो what is the exact protocol? Let us not go by protocols per se in these patients. Okay, so they have to make sense to that individual. They should be able to go back to their activity levels, and they should be moving in a very healthy and efficient way. Okay, so there is a 3P model to exercise prescription, which is understand why the person has come to you. If the person has come to you कि मेरे को सिर्फ पेन रिलीफ करके चाहिए, I am a very bored kind of a person, I do not have any hobbies, I don't like to do anything, I am a very introvert kind of a person, and my primary goal is pain relief. The person is having low self-efficacy. We discussed self-efficacy in the last session. Ability to do a task in a successful manner so that you have a positive outcome. Okay. So these people are low on self-efficacy. They would definitely be hyper vigilant and catastrophizing. Their primary goal is just pain relief. On the other hand, you have a person who is, say, a gymnast. Okay, let's take gymnast for the next example. You have a person who's a housewife who says that my primary goal is I should be able to take tuitions. So I am a person who is having back pain, and I'm not able to sit for long hours of time right now because of pain. But the pain is not bothering me in any other way. I can do my household work, I can do everything. The moment you make me sit for more than an hour, the pain comes, and it's affecting my activity of taking tuitions. Then you know that the primary goal is to improve her endurance for sitting. Okay. The third one is performance. If the person has come to you, these are categorically the cases, post-operative cases, or if you have an athlete or a sports performer, then they are the ones who come to you in late stage rehab. ACL reconstruction हो गया है, meniscal repair हो गया है, you have followed all the mild, moderate protection phases, all of those, and now the person has come to you कि he or she should be able to go back to football or should be able to play cricket. Okay, or if it's a TKR, THR patient, a person should be able to go to the ATM, withdraw money and come back home, independent walking, community walker. So the goal will be improving the performance. So your exercises are going to vary in each three of these categories. How they will vary, we'll discuss it in a while. Even these are some interesting questions which would help you get an insight into your patient as you are planning to start an exercise program for them. It's very interesting to know that what is it that the person loves to do, which he or she is not able to do it right now because of pain. This is very interesting. If you had no pain tomorrow, what is it that you would like to do? I have a case with enterolisthesis, hefty female, and she loves dancing, a bit overweight, so she is currently not able to do any damn thing. Okay, so if you ask her, and she'll come up with interesting answers like I want to dance, or I want to go back to my work, or I want to travel. So this again leads you to the cherished activity. How do you know? If you cannot end up asking your patients ki what is your hobby or what is it that you like to do. Such specific questions will give you specific answers. Fine. Now, as we said in the sense making principle, it is very crucial what you need to do that you can't do because of pain. If I am a tuition teacher and I need to sit for 4 to 5 hours, I am not able to do that because of this pain. And of course, what would you like to achieve from the rehab? These are the questions which are from a shared decision making perspective, wherein there is a therapeutic alliance between you and the patient, and you don't decide, as we normally do, my short term goal for you is pain relief, or my short term goal for you is I will work on strengthening your back because you have back pain. Okay, so I have just, this is a bit, I found them interesting, so I have put these questions and you can make use of these whenever you're talking to your patients. Now what happens exactly? Your exercise selection is going to depend on classically these 6 factors. Okay, what is the current tissue capacity with which the person has come to you? Now we've been discussing this repair process, wherein we classify the repair into a proper repair, then you have your adaptive phase, and you have your symptom resolution. So repair is, मेरे को acute ankle sprain हो गया है, there is lot of swelling and inflammation, and I need to rest my ankle to get enough uh, appropriate healing. Okay, that's repair. Adaptive is, now 3 weeks I have rested because of the ankle sprain, now I need to start loading. So tissue capacity will tell you when exactly it is safe for you to start strengthening, what exactly is the structure, and what is the pathology that is happening there. Okay, if it is a tendon, you know that you need to load the tendon. If it's a rotator cuff, you will need to start some or the other form of strengthening sooner as compared to a disc patient. If it's a disc, you need to allow enough rest and healing to occur. So that's about your tissue capacity. The second part is about pain relief. So are the symptoms modifiable by making some or the other corrections? So we call this as symptom modification procedures. Okay, and if I am giving them exercises, are my descending inhibitory pathways active? So we had discussed this in the physiology, pain physiology. You already have your natural endorphins and enkephalins which are released from your system. So if you are a coper, what do I mean by coper? A person who is able to manage his pain, his inhibitory pathways are a lot more active. Whereas a person with low self-efficacy will not have these inhibitory pathways active. Okay, so that is how you decide. If I find some or the other technique wherein I'm able to modify the movement and the pain settles down or reduces, then I know I can use this specific technique for my patient. Movement strategies: adaptive, maladaptive, or cortical smudging. Now adaptive maladaptive is 3 weeks into ankle sprain, I am supposed to rest. That is an adaptive behavior. 3 months after an ankle sprain and I am still limping, that is maladaptive behavior. Okay, so everything, that's why we should know a time frame for healing of structures. And if we are able to understand that, we would be able to devise better movement strategies for our patients. Cortical smudging is everything in the brain starts overlapping. So the area for your hand gets overlapped by your foot. Because I have ankle sprain, I am giving a lot of importance to my ankle and foot area. And then even if I touch my hand, my ankle would hurt. So this is again a gross level maladaptive pattern that is setting in into that individual. These three are related to your biology and movement aspects. Whereas, as we've been discussing, that these are the people who have a lot of psychological issues. Okay, and they are confounding factors which affect the rehab protocol. Are they going to be compliant to your exercises? They will be compliant only if you are able to create a variety, you are able to create some sort of fun. They should not be monotonous exercises. They should not feel कि आके मेरे को 5 बार ब्रिजिंग कराया, 5 बार क्लैमशेल कराया, 5 बार मेरे को abduction कराया, and then the rehab is done. No. Okay, it has to be some or the other form of fun. What we at Positive incorporate is a lot of animal flow or body weight exercises, then we intermix it with weight and strength training, and we add up a bit of low intensity as and when we feel it's required. So we make it fun, we make it varied. Okay, that helps our patients to be more adherent and compliant. As we discussed, the program has to be meaningful. They should understand that this is probably going to help me achieve a specific task that I value. So if I value going for walks, and if my rehab involves propulsion exercises, I know that I'm going to be able to walk in a better way. Okay. Then what are the patient's preferences? What exactly is what they like? There are certain patients who don't like weight training to be started immediately, which is okay. Can you modify in and around all of those? Okay. And then you will see that your patients are going to be adherent to your exercise program. Belief structure, we dealt a lot about belief structure in the last session, so I'm not going to go there in depth, but yes, you have to understand that their hesitancy, their resistance to movement, to exercises is much more valid, and you have to literally validate that, understand that their fear is not something which we often label them as malingering. Okay, they are avoiding it because of their previous experiences. So somebody who comes to me tells me that I went to a previous physio who made me do this particular exercise, and that has what has led to the worsening of my pain. Okay, I don't blame the physio, neither do I try and correct her judgment on the first sitting. If she says that probably while I was doing a cobra pose and that hurt, I modify it. I was like, we want back extensions, we will get back extensions in a different way. So I'm desensitizing the person from the previous experience, and then chalking out the program, and then slowly trying to tell that what the previous physio did was not wrong. Okay, this is very important, because then once that belief sets into them, it is very bad for their rehab. Okay, and eventually health. Every exercise that you select has to optimize movement, has to get a movement efficiency for your patient, make them physically fit and stronger than what they are right now. Only then you might be able to control recurrence of exercises, recurrence of pain in such scenarios. Okay, now, we generally know whenever we talk about exercises, what we usually end up having a lot of confusion is between the physical capacity and pain. So, majority of our exercise dosimetry depends what we plan. I'll come to that on the next slide. Is to कितना डोज देना है, कितना frequency है, कितना intensity है. So understand that the physical capacity of an individual is comprised of strength, endurance, power, and hypertrophy. Okay, so you will, if the aim is performance, what we discussed in 3P model, then you will chalk out a program which is going to enhance all of this. But if the exercise dosage is for a person in pain, the first P of the 3P model, then you have to understand that you have to be very slow in your approach. So what they do is graded exposure se chalu karte hai. For any pain patient, even me, when the person comes to me, day one, I would sit politely, nicely, calmly with them and understand what are their fears. What are they anxious about? How is the psychological construct of the individual? So that's what comes under graded exposure. While you are talking, while the person is opening up, then you slowly realize कि अच्छा इसको forward bending में अगर fearful है, या if she stands, she feels she gets a sharp shooting pain down her leg, and every time she stands, that fear, that movement is produced, that pain is produced. But you make her go into the position where you're stretching the sciatic nerve to its extreme, you're tensioning the sciatic nerve, but there is no reproduction of the symptom. Then you know that it's a fear, and you have to talk her out of that fear. Okay, graded exercises. Whenever you want to start an exercise, अभी अगर you're talking to the patient, you are counseling the person, you are trying to understand, try and get a hold of why does the person, why would that person need an exercise program? Is it for health? Is it for social inclusion because they feel they are very isolated from the community? Or is that particular exercise something which is most evidence based for that specific condition with which the person has come? This we no longer believe in it, but many a times this comes as one of the factors that you would like to include. Then of course comes to the graded activity. Like you have chalked out a program, you did graded exercises with the individual. Now you need to go back to what is the valued or needed activity for that individual, and let it be defined by the patient. I want to do it at this much intensity and I want to work at this much pain level. I am not going to go beyond this or beyond these many repetitions. Agreed, because it is their valued activity. Let them be the judge while you are planning a graded activity for them, right? Now, these are things which we already know that whenever we are talking about exercise, we like to understand this. But in majority of our pain patients, none of these stand very true. What you have to do is go graded, start slow, gradually improve the duration and frequency of the exercises, and slowly introduce endurance and strength training in your patients. Your musculoskeletal pain patients lack endurance much more than strength. Understand that they are the ones who are coming to you with pain on sustaining an activity. So if I am sitting for long, my back hurts. Or if I'm looking down and working for 3 to 4 hours on my tab, my neck hurts. Okay, so these are low intensity activities which will require you to focus a lot on endurance and proprioception for them, and then move on to strength. By this I don't mean that you will first 2 हफ्ता 3 हफ्ता सिर्फ endurance training दिया and उसके बाद we move on to the strength. No, your strength training, endurance, proprioception can all go hand in hand as the patient allows you to move. Okay, your exercise dosimetry will always depend on what is the baseline pain with which the person has come to you. Uh, what is the irritability of the tissue? Okay. What is the response of that individual to a specific exercise? I personally, what I do is if I'm seeing anybody with a pain levels of say 7 on 10 or more than 5 on 10 per se, I would tell them that I am seeing you for the first time, so I don't know how your body responds to the exercises. It would be a good thing to put you on less exercises and see the response. You may feel a bit more pain than what you are in currently, or you may feel that you are getting better. Either ways, you have to tell me how you felt, and that will help me chalk out a program for the next session. Okay, so this gives them the confidence, this reduces their fear of pain. अगर घर पे जाने के बाद उनको पता ही नहीं है कि मेरे को पेन क्यों बढ़ा, they have one, at least one of the factors at the back of their mind कि I was informed about this. People are fearful of movement. The moment you introduce movement as a stimulus, and they are doing it in front of you because they feel they want to get better, they're obliged to do it in front of you, and they may not even open up and tell you that this is affecting. Okay, but when they are been given a background that probably because you're moving for the first time, you have been stiff for a longer while and you've not exercised or moved, this might increase your pain. So this is stimulus versus response. You have to give them an idea and background. What other factors which are very important also while you are planning a dosimetry is what is the previous exercise history for the individual. So if I have a person who's never moved his butt out of his chair, he is overweight, has lots of other factors which are not healthy, definitely he is going to be very slow in responding to exercises. Okay, which brings me to what are the current exercises levels. Sedentary individual, will take a lot of time to adapt to the positive effects of exercises. Again, with life load, stress, work, we come to the negative pain influences. Always end up, I always ask them, even before I start any rehab, are you sleeping enough? Are you hydrating enough? Are there any stresses at the back of your mind which you probably may not feel comfortable sharing with me? I am okay with that. But would you just make a note of these things and understand how much are you loaded mentally? In types of questions we discussed, they have to reflect on their pain journey. Okay, so what we are doing is we are guiding that reflection. You have to be making them understand that probably, boss, this is not just the structure which is at fault, or this is not just that you're not sleeping enough, you're just probably a lot more stressed out, or something is eating your mind. And if you are able to hit that point to that individual, even if he doesn't share with you, he knows, and that realization helps him get out of that zone and probably would cooperate with you for the next session. The person has to have a belief in positive outcome from exercises. As we discussed, there are many people who believe that exercises are harmful. If somebody who was not into exercise, like there was no previous exercise history, but just because had back pain, decided to start yoga, was taking yoga fluently, ja raha tha sab kuch, but one fine day one particular asan led to pain, and then the person started believing that yoga is harmful for me. Okay, it is your job to help them understand that no movement form is ever going to be harmful for you. Okay, provided it is introduced in a graded manner, in pain patients, introduced in a graded manner, progressed slowly, maybe you need supervision for a few sessions, and then this will keep on working fine. Now this is how we decide how do we want to load these patients. uh, Day one, frozen shoulder in acute pain, bad pain. Frozen shoulder has been there for say 6 months, and the person is just not even allowing you to touch. This is a sensitive person. Okay, the arrow is towards the extreme left. He is not going to respond to your chest press or your shoulder press as an exercise. What that person needs probably is a lot of myofascial release, a gentle touch, hand holding, lot of counseling, making him explain that probably your capsular tightness could be relieved if you relax a bit. So low effort movement. In such patients, what I do is I do not even touch shoulder. I would start working on the proprioceptor somewhere else in the body. They are any which is going to be kinesthetically poor kinesthetic awareness. So if I want to start, I would probably start with the lumbopelvic area. मैं bridging देती हूँ. Yeah, I put them in prone and I give them prone heel squeeze. Proprioceptors will fire, will start understanding that somebody is trying to introduce movement somewhere. What happens in such patients, what is the mistake which we commonly do, ki the person has come to me with shoulder pain and I have to move the shoulder. Okay, that further increases their fear of movement, further worsens your ability to build a rapport with the person. अगर मुझे लंबो pelvic तक भी नहीं जाना है, I start mobilizing the neck. Okay, because neck and shoulder are related. I had one such scenario wherein a person with chronic rotator cuff tear and a positive drop arm. Positive matlab he would just not be able to control the drop of the hand. Okay, and little pain was not a factor, but he was sensitive to touching the shoulder. He had his orthopedics appointment the next day, but he thought he just might show me once. When I saw, I was like, this is clear cut a tear, but because it's chronic, I don't think even your orthopedic is going to advise you any surgery. And he was here for a very short time. So what we did was, I told him, let me just mobilize your neck and relax your neck. Supine, prone, every position. I just did a lot of releases, relaxed the neck. I gave him exercises for neck. Okay. The next day he comes and he tells me the shoulder feels good. I haven't touched the shoulder, so I reduced his fears around that. I reduced his anxiety. The tear is not being managed. The tear has not settled, but the sensitivity which that chronic tear had brought into that individual started reducing. So what you have to understand that patients with persistent musculoskeletal pain need something to desensitize their movement system. You have to make them move. कहीं पे भी करो. So if it's a low back who has come to me, I would start with shoulder. I would start with knee, but I will move away from the painful area. So these are the cases wherein your motor control exercises work, your yoga and Pilates work, because they build in a lot of mindfulness, help them reduce the sympathetic activity, and calms them down basically. Okay, if the person is into the basic level, जिसको pain है भी और नहीं भी, and he's comfortable with his pain, and he is happy go lucky kind of a guy, I'll start with proper exercises wherein I might just want to load him a bit depending on his condition. Robust are your late stage performers. Okay, they are the ones who are going to require explosive heavy work because they want to return to play. Robust men, there is no confusion. You know, they are copers, super copers. They are going to cooperate with whatever movements you try and introduce to them. They want that strength training because they want to get back to their activity. Okay, issues come with a sensitive category, and many a times, as I've been repeatedly saying, we consider that their fears, their hypervigilance is maladaptive. It is maladaptive, I won't deny that, but it needs to be tackled in a specific way. So tomorrow if you go to your clinic and you see a person who's come to you with bad tennis elbow, okay, try releasing the structures around it. We do something called as a one arm pull or one leg pull and bilateral leg pull as myofascial releases. They're fantastic techniques. Try releasing the structures. Ask him if the person is icing enough. If it is 6 months old tennis elbow, you know that he is into maladaptive repair process, healing process. So what you need to do is talk to him, understand what are the baseline factors which are probably not allowing that pain to settle down, and then start with shoulder exercises. Start with a squat, I'm okay, but you have to start movement somewhere for these people after you have counseled them and desensitized them. This is an interesting concept. Again, I learned from Ben Cormack's workshop only. There are people who would always come to you and say ki, exercising for 15-20 minutes is just not possible, I don't have that much amount of time. He's probably the CEO of some big company and who just doesn't want to dedicate time for his well-being, or somebody who likes to move so much that you want to break down and cut down their movements and put them in snacks. Okay, so snacks are something that you have it in between your meals. So how are movement snacks programmed? Extremely low load, 2 to 3 repetitions देने का, रेगुलरली करने बोलो. ठीक है, ऑफिस में बैठे हो, यू वांट टू just get up, stretch yourself, and then get back to your work. We usually focus on moving the painful part with minimal pain. So whenever the person is moving his agar elbow hai, I am asking him to do a bit of flexion extension, there shouldn't be discomfort. So don't tell him to go into extreme flexion and extreme extension. Okay, what you need to do is tell them that move with minimal pain. Idea is just to move, and the idea is they should feel relaxed after that movement and not get more tensed or anxious. This works. Okay, so I have majority of my patients wherein if I tell them that just get out of your office chair, get out of your sofa if you've been working from home, and then take a round in the house, move your do a bit of high knees, and then sit back again to work, then that probably works. Okay, what are the key takeaways? We end up overcomplicating things as far as our patients with musculoskeletal pain are concerned. So understand that if the aim is strength, please start loading. If you want the range of motion, please make them move. Power चाहिए तो load के साथ speed add करो. variability. So you have to learn to vary positions. This is a very nice example of a person who was fearful of bending forward, and how they introduced movement was they gave a very big foam roller, asked them to hold it vertical, and then the person was supposed to bend till the top length, मतलब ऊपर ही पकड़ने का और उतना ही bend करने का. Then they made the person grip the foam roller a bit lower, okay, and then asked the person to bend forward. ऐसे करते करते धीरे धीरे we started increasing the depth of the bending forward. Okay, so this is varying the positions. Somebody has forward bending painful, then you start working with knee to chest position. Okay, give them knee to chest. So knee to chest, quadruped में sitting back on your heels are varying positions wherein you are able to create a variability. Okay, if you want to build up endurance as we discussed, then what you have to do is go longer, increase the repetition sustenance time. Okay, and gamify. I said agar fun aim hai, I have patients who just come to me, they say they love coming here because there is a lot of variability in the exercises and we just love to spend time here moving and exercising. Introduce fun. Okay, you don't have to be an exercise genius. You don't need to know कि कितना specific angle में, कितना degree में, कितना tummy tuck करके ही I have to give that exercise. You don't need to be an exercise genius to help your patients. What you need to focus is definitely on the aims, values, needs, and the fun aspect of an individual. While you are introducing movements, avoid excessively provoking pain. Okay, do not give a movement which is going to increase the pain a lot more. Okay, empower people to self manage their dosimetry. अगर मेरे को 5 repetitions के साथ पेन हो रहा है, so my minimal repetition can be only 2 or 3. I always tell them that I want quality movement instead of just doing 10 repetitions ka 3 sets. Create a movement habit, which is very important because they are kinesiophobic, they have fear avoidance model. They are just not going to move because you want to start prescribing an exercise regime. No, you have to create a movement habit, and movement snack becomes a very good way of introducing the movement habit. Last and very important is you got to create a positive movement experience for your patient. As I said, if one asana of yoga led me to think that yoga is harmful for me, I have developed a negative movement experience. You have to get over this for your patients because unless they move, their pain is never going to go away. And this is something that you have to explain them. You know, OA knee hai, to please, if the pain levels are not bad, stop starting with a static quadriceps. Stop starting with a static glute or a VMO strengthening. Give them sit to stand. Give them knee drives. Give them propulsion exercises. Make them confident that they are capable of movement. Okay, this is what I mean by creating a positive movement experience. This is something which I have taken from Greg Lehman ka blog. I have shared all those blogs on the drive, and it's very nice, right? There are only two criteria wherein your patients can adapt. Either they are human, which they are, I think, and they're not dead. Okay, so all the human beings have amazing capacity to adapt to the stresses that we are trying to put. Only thing is we have to be careful that at what level, at what stage are we introducing that adaptation, that load for that person to adapt, and is the capacity there. So here the load capacity model comes into play. अगर मेरे पास capacity नहीं है to sustain that specific load, I will not be able to manage it and I will end up in more pain. Whereas if I am working out and I am building up that much amount of strength and capacity within me, then I can very well accept the loads which have been imposed on me. Okay. So yes. There are many paths to Rome, but there's no need to carpet bomb one of them. Do not focus on a specific protocol. मुझे मैकेंजी ही देना है या मुझे मलिगन ही करना है या I am going to put the person only on animal flow or I want the person only to do yoga or Pilates. No, you have lots of options. What we generally do at Positive is we put our patients through all the exercises. There are days when it is only high intensity, there are days when it is absolutely low intensity motor control exercises. So we are not contradicting any or either recommending any specific technique or an exercise protocol for your patient. Understand that the exercises, the movement strategies that you are trying to introduce for your patients have to make sense to the patients. They have to be meaningful for them, and that program should be able to get that person back to his or her valued or cherished activities. Only then the rehab is successful. With this, we come to an end of this. I'll once again say that because this was our last seminar on the program, educator program. Those who have attended all three seminars can attend and be an active part of our community program. I am doing one such on 19th of Feb at Mulund West. Interested people can DM me directly. Okay, these are the community programs which we are trying to conduct so that we are able to make pain literacy, pain education accessible to everyone, and improve the uh, way in which a person can get out of pain, understand pain better. Okay, so for the certification you have to be attending one of these community programs with us and definitely conduct one such program within your college or residence. Okay, with this we come to an end of the presentation, and I would like to have questions if there are any.
Hello, ma'am.
Yeah.
Ma'am, I have one doubt. Ma'am, now I'm currently posted in MSK OPD, and there's one patient who is a chronic neck pain. She has neck pain since 9 months, and now earlier she was having she had cervical spondylosis, means it's medically diagnosed. But now the facets are not tender. She just have the anxiety, and she's very anxious, and she has a psychological issue. So today I was giving her trigger release for levator scapulae, and then I suggested for ultrasound. This I had given last time also. So now, and she was the patient who was seen earlier by another physiotherapist, and then she was referred to me. So earlier, that physiotherapist had just given some massage over the occiput area, and she felt it very nice. She is like, I felt my pain came down to zero.
Hmm.
So, but and she feels that it's like a trigger release. We are giving some pressure. So she always tells me to do that, but it's not that which is going to help her. So how to get her back from it to
So what
stop
I
that, because she's getting
yeah
addictive to that.
yeah what I generally do is I tell them that this is a very good way that some of the other techniques is working very nice for you. These are passive people. Okay, so they love passive therapies a lot. Now if you try to argue against that or to counter her opinion, you will not be able to do any justice, or you will not be able to reach anywhere with her. What I generally do is I was like, okay, if this myofascial release has worked for you, educate what this has exactly done. So what does your suboccipital release does? It reduces the tension around your neck muscles, which probably opens up the facets. Okay. And now that has happened. Now what we need to do is for this pain not to recur again, we would like you to put you on some strengthening exercises which will give you a long term relief. So for 2 or 3 more days, I would continue doing suboccipital release with the patient. But along with that, I'll gradually introduce my exercises. I wouldn't even go for ultrasound or the elevator cap release. As we discussed in the pain physiology, majority of these are outputs of the pain. They are not the causes of pain. What you need, if she's a cervical spondylosis, which is a long term case, what you need to do is strengthen her neck muscles. Okay, so if I want to strengthen and build up endurance in my neck muscles, I need to make her move. But if I want to oppose her opinion that yes, abhi ye zaruri nahi hai and this is not going to work in the longer term, it will contradict her. So instead of doing that, what we say is get a middle ground. We talk to them saying that we are going to release that, but understand that that is going to give you a temporary relief in your pain. What is going to help you more if we start is with neck exercises, neck and shoulder girdle exercises. So this is how I would usually handle such cases.
Okay, ma'am. Ma'am, actually, I've started with those exercises, but every time she's like that, I want that also along with the exercises.
हाँ तो 5 5 मिनट करने का. This
Okay,
is
ma'am.
actually there. See, they are the ones who are not confident. So these are low self-efficacy people, as we've been discussing. So when you are doing that, even if you're not even releasing, but you're touching that aspect and area, and then you start uh, gradually increasing the intensity of your exercises, the person will actually start realizing that this is what is working for me more. Education will help her understand that more, but every one of us is not at the same intellectual level, and you need to match the intellectual capacity of the individual, which is why I'm saying that I would continue doing that for 5 sittings more of the suboccipital release. And while I am doing that, I would tell her that, I know this feels good, this is fantastic technique, but what I would suggest you is, sticking more to the exercises. I'm doing it here once, but you are doing the exercises on your own at home. So what do you think is helping you more? The more you move will help you more. Okay, this is how you try and counsel them.
Okay, ma'am. Thank you, ma'am.
Yeah. Any more questions? Fine. So those
What was
moving,
the name of the workshop?
sorry,
The workshop that you were talking about?
it was movement
The other one.
prescription in pain. If you just start following Ben Cormack on Insta, and you will get a उसके पोस्ट में मिलेगा मूवमेंट प्रिस्क्रिप्शन इन पेन या मूवमेंट प्रिस्क्रिप्शन इन पेन, ऐसा कुछ तो था.
Okay,
या
thank you, ma'am.
या Good. So I think we end the meeting here. I hope you guys have a good learning experience. If there are still any queries, any questions, please do get back to me. My number's there in all the presentations. We've updated the drive to include very interesting blogs by Greg Lehman, who talks a lot about how would you actually plan an exercise for patients in pain. So please utilize articles, read the articles which are there on the drive, and connect with us to be a volunteer for our Pain Collective, the initiative that we are taking to bring in a change in managing the musculoskeletal pain. Thank you guys for your time. Bye.